So Doug and Christina from OneUp are going to introduce the next panel. So I'll hand it off to you guys, Doug and Christina. And if you want, feel free to turn on your video.
We're very pleased, John and Nick. That was a great overview and presentation. We are all ready to start to activate it. And then speaking of activation, we've got Lenel James and Heather Kennedy. And Amit Shah is working to get free as well, if at all possible. They're going to talk about the work that's been done in the Blue Cross Blue Shield Association and across multiple blues, and how they're getting ready to get data, their data to the patients. And with that, Lenel and Heather, take it from there.
Of Tennessee, as was identified, Amit Shah will be joining us. If he can get free, he'll join for some slides he has at the end. Just as a bit of background on Heather Kennedy and I'm active at the association for the last 15 years, active in standards with HL7, HIMSS, AHIP, and AHIP, and also actively involved with the WEDI organization NX12. Heather has been active as part of taking the pledge that Anish talked about. The folks that took the pledge to the Blue Button included Heather Kennedy and Amit Shah, so they can maybe share a little bit of insights on what that's like to be at the White House and take a pledge to technology. Both the association, Blue Cross of Tennessee, and Florida Blue are active members of DaVinci and are founding members of DaVinci. In terms of the CARIN Alliance, Florida Blue and the association are active in the CARIN Alliance, and all three of us have been active at interoperability connect-a-thons at HL7 for HL7 FHIR. We all have more background than we can share, but we really want to get into the meat of the slides. So if we'll go forward, we'll talk more about the agenda for the next half hour. Want to talk a little bit about Blue Button, how we got here in terms of that initiative, and Anish talked about it in terms of Seema Verma putting down that marker 2 years ago. I can tell you the association and the Blue Plans were listening, and you'll hear more about what we did when we heard that. We'll talk about FHIR. I know with the presentations that have come before, there may be some information you've heard, but we'll recap it for someone who may not have been on the earlier sessions. And then we're going to shift to Heather sharing some of her real-world experiences in implementing Blue Button and where we are now and where we're going. And then we hope to leave time for questions. That's how we're going to handle the rest of our session. So next. Part of this discussion, everybody's talking about FHIR. Let's take a little bit of time to talk about it. It's the next generation of HL7 standard. Everybody's heard about the V2 messages that are used in lab and ADT, CDA, consolidated CDA that is part of the XML version of documents. HL7 FHIR is APIs. To help the computers, again, talk to each other. These FHIR resources are reusable and standardized for a variety of the key areas in healthcare, the patient, the practitioner, device requests. I think we're probably well over 150 resources are defined. These resources help us do some common exchange methods, from just messaging to documents to services to being at rest, rest being representational state transfer is, again, part of web services. As I'm talking to people around the country and the plans and some of our organizations and providers of technology services, FHIR is really the healthcare version of what you see every day, from hotels.com to other web-based services that are on your cell phone. This is the healthcare version of that. And what we've seen, and we'll be showcasing some of that, is the use cases in value-based care, the use cases for providers and payers, for payers to interact with consumers, all can be supported by FHIR. And you see in the diagram on the right the level of areas for which FHIR can play an active role in the healthcare ecosystem. Next. One of the things is just want to highlight this groundswell of FHIR activity. I think everybody was around when Apple announced Apple Toolkit and the fact that they baked FHIR into the operating system. And then it started with, I believe, 7 to 9 health systems. Now it's well over 100 health systems, well over 1,000 provider organizations where you can go to your Apple Toolkit. And if you've been received healthcare services, whether it's Advocate in Chicago or Mayo Clinic, you can click on that, and using the existing protocol for getting into their web page and portal, you can go into Apple and start downloading your data. But roll forward, we've got in October, we've got over 80% of hospitals and clinicians have access to a certified EHR that's on at least release 2 of FHIR. And as Anish pointed out, and Dr. Halamka did too, people are on different versions of FHIR. However, the FHIR servers can talk to each other and know which versions of software they're using and react accordingly. But moving forward, again, there's DaVinci starting as a collaboration between payers, providers, and EHR vendors, active with FHIR starting with just 9 use cases. Now we're at 17 use cases and growing. And there's a beautiful map that, for the sake of time, didn't include in this diagram, but ONC has published a heat map that shows the current implementation of FHIR across the United States, and that heat map is pretty well lit up in all the major urban centers throughout the entire country. And we're doing balloting, and of course the federal rule just came out. So again, FHIR has been moving forward across the ecosystem and is now available, and we'll be talking about how we've used that in the Blue Button context. Next. This all started with the Blue Button. CMS has a vision. It started with the VA, moved to ONC and pledges, and then CMS implemented a Blue Button for Medicare, did a multi-year, multi-million-dollar build-out to make their Medicare claims adjudicated data available to consumers through an app. Well over 20 vendors are certified to provide that service. If you're a Medicare beneficiary, you can get your Blue Button now. And again, it's an API-based standard based on version 2 of FHIR, actually version 3 of FHIR, somewhat customized for the unique back end of the CMS claims processing engine, but that Blue Button is up and in production. Next slide. This is the journey that's driving the Blue Button, and again highlighting the various dates of service. And what's indicated in this slide is the new thing is the federal rule is out. And in that federal rule, as Anish mentioned earlier, for January 1st of 2021, the payer directories need to be available through open APIs, and then claims-based information in addition to any available clinical information. As Anish mentioned, if it came in through your HEDIS audit or it came in through analytics in your relationships with your providers, if you've got that clinical data for a Medicare Advantage member or QHP or CHIP, you're required to make that available through an API. In addition to the claims-based post-adjudicated data, making sure that clinical data, that lab data, that pharmacy data would also be available January 1st, 2021. Moving to the next slide. So part of that Blue Button is the pledges. I mentioned that both Tennessee and the association and Guidewell, Florida Blue Cross Blue Shield Association, Florida Cross Blue Shield, also took the pledge to engage in the Blue Button in terms of a commitment to do real-world testing. And in addition to doing real-world testing, Heather's going to be able to share more about getting beyond testing and moving into production planning for 2020, ahead of the deadline of 2021. Next slide, please. Oh, I think this is a build slide, and Heather, your turn to shine.
Thank you, Lenel. So as Lenel alluded, I'm going to share a little bit of the payer's perspective of how we started to implement or start towards implementation for production this year. We started our FHIR journey probably about 2018, and with the intent of what Anish had mentioned earlier, payers up first. We kind of assumed that's where that was heading with the notice of proposed rulemaking, and started down that path. Here are some of the discoveries that we made. Our first year out the gate is we realized that there are 3 different types of FHIR implementations. I refer to them affectionately as there's a smothered FHIR where you might have IT managing it, and you'll see a lot of pilots. They'll be at the connect-a-thons. They do a lot of great work. However, they don't have the business sponsors to move forward. And without the business sponsors, nothing goes to production. So smothered FHIR is great for controlling it. It's just, if you actually want to get to prod, it's difficult. So the next one I like to refer to as wildfire. You can have really excited business partners, but maybe they don't always have the clear understanding of the use case. A great example of that is like prior authorization. Prior authorization has a very specific use case for outpatient. However, when our business hears prior authorization, they often think that it might be all of the use cases. So while I would love to implement prior authorization out the gate, I have to kind of control that conversation and be essentially the IT translator. This is between business to say what's practical, and then also offer parallel approaches to implementation. So FHIR might work for this use case or this specific scenario for prior authorization, but we might do this other scenario until the implementation guide's ready for the other scenario. So what we call that is controlled burn. And that's right now, currently in our infrastructure, it's a strategist or an architect leading it. And we're bringing in project managers now that we're actually going to production. But over the last year, it's very much been managed by our strategy and architecture departments. We partner with both business and IT. You'll see us at the connect-a-thons together with the IT and sometimes with business resources to actually make sure that those use cases are moving appropriately. We keep a strategy roadmap that kind of helps us keep everyone on task. It's very easy to get excited about new use cases, especially with DaVinci doing such great work. However, we like to keep the goal in mind. And I think now that we have the reg, that's actually going to help us significantly. So how did we get there? Over the last year, we started DaVinci in 2018, so we're a little over 18 months old. With FHIR, we had a clinical data exchange practice before. It was HL7 version 2, and we're still operating that. Like I said, parallel processes. We started participating in connect-a-thons, and actually Lenel probably gave me full guidance on how to get started in that. So I encourage you, if you see him at a connect-a-thon, to talk to him. But we started attending connect-a-thons even as an observer out the gate, and then actually started participating and getting a development environment stood up. In that, we also pledged to do the CARIN Alliance, as Lenel had mentioned earlier in the previous slides. We also publicly committed to our members, and that's something that I think we've done a little different. I personally shared my own patient experience. I think we've all heard several patient experiences over the last few days. But I wrote mine up and explained from my perspective, both as a health IT nerd and also as an individual who had cancer, how this future world of applications and data accessibility is really imperative. I'm 2 years cancer-free today, and my phone reminded me. I don't keep up with it daily, but my phone and app that I was using actually reminded me. So it's things like that I think keep patients in check. And it's something that has real world value. In 2019, we actually stood up our production FHIR server. So we have one going now. We have several development use cases that I'm going to talk to you about in the next few slides. The main one being the CARIN Blue Button is the one that we're furthest along with. We actually tested at the, I think it was the CMS Connect-a-thon, and we've tested several other use cases through other Connect-a-thons that I'll talk about with DaVinci on the next slide. through that, we're looking to deploy a production CARIN Blue Button API. I don't have the go live date that I can share just yet, but we're working actively with that in mind. We have tested with real world data in a development environment, but we have not started down the path of deploying applications or looking at what that might look like in the future. So lessons learned, if you're a payer starting out, and it might actually work for provider practice as well. Technology is really easy with FHIR, to be honest, but the business is pretty difficult. The technology might take a little bit of a different mindset than one your staff might be traditionally used to. It's more object-based, so it's easier, but on the same note, it's easy to find developers for it. Business, on the other hand, having that person who can negotiate that skill set between the translator and making sure that business is aligned with what these use cases mean is imperative. And I found that can be the biggest roadblock, is not understanding the requirements for implementation and how it impacts all of your production systems. Knowing your value story, with the regulation, that's going to be significantly easier. Obviously, this was prepared before that was released on Monday, but knowing the value story is imperative, because there are other use cases outside of the ones that are called out in that regulation that I think Anish said it eloquently earlier. It's really, what are you trying to do? Are you just trying to meet the bare minimum requirements, or are you actually trying to improve your member experience and actually prevent provider abrasion? With those goals in mind, knowing your value story, you should be able to implement some of these other DaVinci use cases along with some of the use cases that are called out through the reg. And FHIR is not always a new capability, like I alluded to with prior authorization. All of us probably have a great prior authorization tool that we know and love today. FHIR is an improvement on that. We will look at how we can improve that, but I recommend that when you're doing your assessments for which use case to implement outside of the reg ones, knowing what processes exist today and looking at how you can complement those processes with these new capabilities is really beneficial. I found a lot of success there. So this is the Blue Cross Blue Shield of Tennessee use case areas. A focus, and this is what we've done outside of CARIN Blue Button. So we focused on DaVinci. Now these are just the ones over the last year. There were a few the 6 months prior, but data exchange for quality measures, the prior authorization use case, the full workflow we've looked at, and we plan to continue looking at for implementation, the clinical data exchange and alerts and notification. And all of those use cases are really beneficial in our day-to-day workflow. And we will continue down this path, obviously moving towards the direction of the ones called out in the reg, but also wanting to test all of the use cases, really. I'm going to turn it over to Lenel to talk about GuideWell's implementation.
Thank you very much. Let me take a moment to step back and give you a perspective for not only the role that Heather has played in using the connectathons and kind of how the connectathons have tied to these use cases, which you see on the screen. As I mentioned, there's 17 use cases that are active in the DaVinci world, and we've sorted them by general areas, whether it relates to quality improvement, whether it's a burden reduction for providers, tied to member access, again, Blue Button information for the member, and also for the member to be able to exchange with their caregiver. We've got some process improvement tasks. I think Kirk Anderson was talking about bulk data, and bulk data has been implemented as part of the risk-based contract member identification. Who are the 1,000 or 50,000 or 788 patients you want information about, and being able to share that with the provider and have that information come back, or using bulk data for the consumer to be able to ask for a provider directory data for all the specialists, thoracic surgeons available in their zip code, as one example that might be a large request across multiple jurisdictions. And then to the right, the various flavors of a clinical data exchange. These things have actually been in play in all of 2019, specifically both Amit and also Heather were involved in the September 29 Atlanta Connect-a-thon, where many of the DaVinci use cases were being fielded. And related to Blue Button, I wanted to highlight that Amit had his Blue Button reference implementation present and was interacting with several vendors of Blue Button apps to exchange de-identified test data all the way back in September. And actually, I know Heather was doing the same thing. So all the way back to September of last year. And then Heather actually, the CARIN Alliance in November, or am I getting my dates wrong, December, did a Connect-a-thon hosted by New Wave in the Baltimore area. And then CMS in January of this year hosted its first Connect-a-thon that had both the CARIN Alliance, DaVinci, and the folks, the only people missing for key FHIR accelerators were Gravity. Earlier in the call, some of you may have heard mention social determinants of health. One of the accelerators that HL7 has beyond DaVinci and Argonaut is also the Gravity project, which is social determinants of health, looking at things like food insufficiency or transportation. Think of Lyft and Uber. So I say all that to say there are a lot of activities going on in the healthcare space, but at these events, at the CMS event, the CARIN event, and also the September Connect-a-thon, and also the one that was in for those that got a chance to go to Sydney, Australia for the Sydney, Australia meeting of HL7 in early February. All of these use cases are being used. So again, the payers and the providers are very active in implementing these use cases. In specific, shifting to what GuideWell is active in doing, everything that you see highlighted in red, all of those use cases are in active development and pilot testing for 2020. And to be specific, eClinicalWorks, Cerner, and Allscripts across different combinations are working with providers, health systems, and large clinical practices in Florida in conjunction with one of those three EMR vendors to actually use live PHI in 2019 as part of what Anish mentioned. People took the pledge for real-world testing. Well, real-world testing for a payer means I do de-identified data, and then, as Heather mentioned, I test out of my test system with live production, but in my test environment. And now in 2019, Heather, Amit, several blue and non-blue payers that are active in the DaVinci project, and many that aren't active but are active at HL7, because you do not have to be a member of DaVinci to use these HL7 standards that are available for Connect-a-thons that are published or in ballot, but again, in the HL7 parlance of open source and available. Go to the web, type in one of these names in HL7 and in FHIR, and it will take you through Google to find that available implementation guide that's on the HL7 web page now. And at the next Connect-a-thon, whether it's virtual or on face, depending on where we are with the current virus, we should be in great shape. But all of these that are highlighted are active. Amit told me one interesting story. He got to go to the Allscripts user conference last year, and as he explained their active role in coverage requirements determination, which is to the left, coverage burden. Coverage requirements determination is one of the use cases that allows you to know if there's a prior auth, yes or no, because many providers in their workflow, if they know that particular procedure for that patient and that insurance coverage does not require prior auth, all they need is a number that confirms the payer has said that doesn't need a prior auth and they can move forward. In the old paradigm of faxes and phone calls, at time of billing the claim, all of a sudden everybody's got amnesia about was that approved. Well, coverage requirements determination using FHIR, real-time handshake, real-time documentation, a great opportunity to reduce burden. At the end of that presentation, Amit had a line of Allscripts provider users lined up discussing their interest in being part of a pilot. As I understand it, he has 10 health systems in Florida lined up in queue because they'll be sequential because, again, there's only so many tech people available to go live with this on both sides of it. But right now in Florida, there are 10 health systems queued up to work on these standards in pilot with live PHI in 2019. Again, the federal rule says we need to be ready as payers to do Blue Button on January 1st, 2020. As you can hear from the discussion of what GuideWell is doing and the discussion of Heather, several payers, several Blue Cross Blue Shield Association plans will be ready. As Anish pointed out, were people listening when Seema Verma said this is coming? This is an example of the association and our plans. We're listening and we are ready, and we'll be going live with some of our Blue Buttons will be live in production, not January 1, 2020, but in Q3 or Q4 of this year. Though as I say that, I know, Heather, you're sitting there listening going, yeah, Lenel said Q3. Let me see what we can do for Q2. So I applaud you if you can beat my projection of Q3, Q4 going live with Blue Button well ahead of the deadline. That's kind of what we're doing. Just as a wrap up for this slide, as you look at the document, it's color coded, and you folks will have access to these slides. If it's color coded in gold, that means it's expected to be balloted for trial use. If it's available in silver, that's going to be early September, which means it would come out July in terms of the ballot timetable. And in fact, if we look at Payer Data Exchange and eClinical Data Exchange, I'm forgetting, we're talking last year. So this stuff is actually in line of sight for actual publication as a draft standard for trial use. So those things that are in silver, depending on how things go for the upcoming May meeting of HL7, hopefully there'll be the approval for the ballot reconciliation and they will shift into publication as formal standards. However, they are available to use now. It's just the caveat, buyer beware. Until the ballot's done, until it's published, some things may change, but from talking to several of the vendors that are active with HL7 FHIR standards, one in particular built production on version 3, and they said when version 4 FHIR came out, it was less than a 2-month effort to update their software and reissue it. So in the FHIR world of APIs, the challenges of updating your software and moving it, it's a new world in terms of the rapidness that we can do updates. So that's a little bit of a background on what GuideWell is doing, their plans for 2019, and expectation of being very ready for the January 1, 2021 date, just as is Heather. Next slide. That's contact information. Please feel free to reach out if you have questions on FHIR, Connectathons, where some of these initiatives have been discussed. There will be a variety of upcoming virtual webinars, much like this, coming from HL7 DaVinci, coming from HIMSS, coming from other third parties. It's going to be an information-rich environment in terms of WebExes for the next several months. So I think I'll turn it back to you, Doug, for questions.
Yeah, so first, thank you so much, Lenel and Heather, and thanks for your leadership. We've actually got Candace on from the patient group on early. I have a question, and then we may have a chance for her to ask a question. But first, Lenel, you're from the Blue Cross Blue Shield Association, I believe in Chicago.
Yes.
And Heather, you're in Blue Cross Blue Shield Tennessee. Can you all talk about, we've got Blue Cross Blue Shields across the country. These are major important initiatives that you work on collaboratively. Can you talk about how you roll those out and provide leadership from your perspective, Lenel, and then Heather, how you work with Lenel and the other Blue Cross Blue Shields for implementing such important initiatives?
Thanks, Doug. That's a great question. In the association environment with the 36 independent licensees, we work together in a variety of ways. We have our own Blue Cross Blue Shield National Summit that meets every year across the system. We also have a variety of association work groups where we exchange best practices and actually get together with groups. Heather is part of a team of plans that have been working on FHIR-related initiatives, so that we have monthly and bi-weekly calls, every other week calls, where we're sharing status of our work, sharing best practices. I know that Heather and Amit and Jim Adamson, for example, from Arkansas Blue Cross Blue Shield, have talked a lot about their joint Blue Button initiatives to share information, so that one of our objectives is not to have 36 Blue plans do the same thing 36 times when one or two can be on the cutting edge and share that information. That's one of the ways we work together. The association actually has our own technical infrastructure that links the plans together, because we are sharing information for our national account business that goes across the country, so that plans in their particular service area can exchange information across the system, so that there is a seamless coverage for both care coordination and claims processing across members that maybe have a contract and service with Tennessee, even though the member may live in Florida. The association, Florida and Tennessee, can interact electronically through technology the association has to make that data move. That's my perspective. Heather, you're one of the people we coordinate with. What's your viewpoint on that world of the Blues and how we coordinate together?
So I think from the Blues community, the onboarding process, at least with DaVinci especially, and actually getting acclimated to FHIR, because like I said, it's only been 18 months for us, but having the community with a lot of the other Blues like Alabama, Florida, HCSC, IBX, kind of there to kind of help guide us because we came in behind them, was really helpful. And then also we found that just in the community, and it doesn't have to necessarily be Blue, even within the DaVinci community, we've seen a lot of people who are working collaboratively with their vendors. Florida and I actually share vendors, and we work with our vendor partners at FX quite frequently to actually build out our roadmap for what we need for FHIR. So like EdFX will provide resources, and that's in their product. So we've been working together just to kind of figure out our roadmaps. But even outside of that, through the Connectathons, there are other people using similar product stacks, and I don't think it's competitive, at least in the DaVinci community. So I would encourage you to find people who are working on similar initiatives to you, and see if there are ways to partner to get that initiative out, especially in a non-competitive manner.
Great. And I have one more question. Then Candace, who is going to moderate our patient panel, has some questions for you on access to data. But first, I know there's some discussions. The Blues already share data to some degree. Could you all comment on how you think through, Heather, you raised a good point. If I'm living in Tennessee and then I move to Massachusetts, for instance, what are your expectations? Do I get my data from a portal from Tennessee? Do I get my data from Massachusetts? Are you still working that out? You've been kind of working your way through. As a technologist, we look for, first how to make the data available and then improve it over time. How do you work on that in the Blues?
Well, let me take a first shot, and then I'll see to what degree Heather agrees with my assessment. The first part of that, it depends on how that person moved. if that person got a transfer and the company, that person still works for the same company and they've just moved from Tennessee to Massachusetts, then they still interact with Tennessee. That employer is through Blue Cross of Tennessee, and it doesn't matter where the member lives, they're still being supported and serviced by Blue Cross of Tennessee, so nothing would change for that member other than their providers. And again, the providers that are available from both Tennessee and from Massachusetts would be in-network providers for that member. However, if that member is moving to Massachusetts because they have a new job, and when they get the new job, that new job is serviced by Blue Cross of Massachusetts, we have a process to move our data from appropriate claims-based data from Tennessee to Massachusetts, so they get a running start on that member, and then that member's data that would be that's the one open area, I think, Heather, which is the data that's available from, well, actually it's not open under DaVinci now that I think about it. So that information from Tennessee, using the standard that DaVinci is developing for moving data from payer to payer, would be used for Tennessee to move its data to Massachusetts, and Massachusetts to get that data, combine it with theirs, and then the member can see all their data longitudinally. And I say that because we've already, as part of the DaVinci booth and kiosk, we've already done some proof of concepts for the Association of Healthcare Services Corporation and Humana to move data, de-identified, of course, as part of our pilot work with the DaVinci for the HIMSS booth. So we're not just talking about it. We've actually done that work already in Connectathon and are working this year to make sure we're ready to do that at scale. Heather, anything I may have missed or mischaracterized about that?
No, I was just going to highlight the non-blue to blue, but I think you've touched on it already.
Great, that's super helpful. And I've been in the technical discussions. It starts easy, and then you have to work through it, and people are really working towards that. And then I'm very pleased to introduce Candace Lerman, who is going to be moderating our patient panel. She had some questions, and she can, Candace, you can introduce yourself early, and then ask Lenel and Heather how they're thinking about it from the perspective of the Blues. Candace?
Yes, hi there. So my question for you, in the rare disease community, as a rare disease patient, I work with a lot of groups that are building patient registries and understanding just courses of treatment for their patients in hopes to develop better drugs and treatments for their condition and also improve the standard of care. So one of the areas that we're looking at right now is claims data and insurance data, because it sort of paints a great picture of what patients and caregivers are doing for especially children with rare diseases. And the big question is, what can patients and patient groups do to access data from Blue Cross Blue Shield? And is there a network or a way that they can develop a relationship? So perhaps every couple months or so, they can get some either de-identified data, or if the patients agree to give their data through Blue Cross to the patient registry group. Can we facilitate these sorts of relationships to help these patients and these parents kind of drive science for better treatments and possibly cures for some of these rare conditions?
Wow, that's a great question. It has two answers. One, for the patient themselves in this new paradigm that's required by January 1st, 2021, the patient can request to their payer of coverage, and they must be given that data in a FHIR-based platform. Many patients already have, through their existing payer, a portal or an app that has much of that claims-based data, providing EOB, which we would call the post-adjudicated claims data. Almost everybody has that right now through the Blue system at their local plan, but it's not FHIR-based, it's custom for each plan. Your question, though, was asking if an association on behalf of the members could get the data. That's a different question because we're HIPAA-covered entities, so there'd have to be a business associate agreement in place. That's pretty challenging and complex, and that would have to be done on a one-per-one basis. And again, it's, well, if you wait till January 1st, all your members are going to have to be able to get that information. Heather, your perspective on working with an association as a third party, getting the data on behalf of others, I think is challenging, but you may have seen some of that in the field. Heather?
No, I would agree with you that I think it's going to be a one-to-one for each blue at least, unless the association had a better answer. I would say that, and I can't think of the names off the top of my head, but there are a lot of communities out there for data for change. I think might be one of them where you can actually get patient data, de-identified data. I don't know that it's the administrative data that you're looking for, but I think that's an interesting challenge. I would kind of side with Lenel, and the easiest way to go about this is to actually have the patient advocate to share their data. And I've seen in the applications, a lot of the applications actually have the option where they're looking for ways that patients can advocate to share their data outside of just maintaining their data. And I think that's really promising for your type of challenge.
Let me add one thing I forgot, Candace, which is pretty important, which was that the access for research. I'd encourage you to go to bcbs.com, not BCBSA, but bcbs.com, and look for Health of America. And in Health of America, we've got reports that have been done. The association has a relationship with several universities, and we meet with them on an annual basis. Those universities, and if your organization has a relationship with one of those named universities, they're allowed to submit a request to do research with the caveat that research must be shared with the entire country when it's done, and based on a review process, that university and potentially your partner would be reviewed, and if approved, could actually access the de-identified data of the largest claims database in the world, which would be the association's Access database. So there is a way to get there, but you have to go through one of the pre-approved universities that are authorized to hit our de-identified data. But there's a place, and you can see the kind of work that's been done across various disease states, and potentially this is one that might be some new, interesting research, which is part of the protocol. Something new that hasn't been done before that would benefit the industry is part of the assessment and review. So take a look and see if it works for you.
That's great. And one last question, and then Christina will introduce Candace and the patient panel. But when you've been leading these efforts, I'll start with you, Heather, and then Lenel, you've probably seen it from the beginning. We know that people were nervous about sharing patient data. We're custodians, and a lot of issues that I think Candace has worked to break through. What's the environment feel like, Heather, for you within your environment as well as across the Blues? What was it like when you started, and what's it feel like now? Are people getting more comfortable? Is it still pins and needles? And then Lenel, you can wrap up from there.
So when I started this initiative, I actually had just come out of cancer myself. And I had been in the healthcare industry about 15 years and never tried to access my own data. So it was interesting and enlightening to actually go through that process. And in that process that I highlighted earlier, I kind of glazed over it, but I did share my own story. And I got a lot of interesting feedback from the public perception of that. I think people are interested in having access to their data. And I think we've seen a big shift if you think about Facebook sharing data and a lot of social media coverage from the last few years. I think people want to see their data if it's available. I think Candace, leading the charge for trying to find data for solutions and for cures, I think highlights a lot of the need for it. I always say that I don't think that our end users of our apps for this type of functionality are going to be the people who see the doctor once a year. It's going to be the people who actually have a challenge that they're trying to address. And I think for those people, there has been a significant shift because they see the value in being able to be your own patient advocate. Lenel?
Well, as part of wrapping up in the maybe 30 seconds that's left, let me highlight that we, in addition to the work we're doing with research on de-identified data, many of you know as part of 21st Century Cures, there's the All of Us initiative for clinical research, and we're active with the Scripps group, we being the association, and our de-identified data. So there is yet another way that the industry has access to some of the information we have. So that's, stay tuned, because we're very eager to make sure the members of the Blue Cross family, in terms of our members, have access to participate in research if they want to be able to get their data routed to research institutions, is an initiative we're trying to work on at a high degree of activity. And FHIR is actually giving us some more windows to do that. Let me wrap up by saying the Blue Button and the Blue Button initiative we think is going to be extremely powerful in terms of consumers. And as Anish Chopra said earlier, people talk about how consumers are reluctant to share their data. When they're actually dealing with a healthcare challenge, they want that data and they want to get it in whoever's hands can help solve them. And all this issue about privacy, security, it's important, but not if you're trying to make sure you have a good healthcare outcome. You want to share it with as many people as can get it who might help you with that issue. And I think the Blue Button initiatives are going to be a powerful tool to get that moving for consumers. Doug, thank you for inviting us to this event. Heather and I have enjoyed it. Hopefully we shared some information that'll help people. Candace, have fun on your next session.